Hi, my name is Alison Fildes, and I'm a researcher in the Department of Primary Care and Public Health Sciences at King's College London. My colleagues and I recently published a paper in the American Journal of Public Health exploring the probability of an obese person attaining normal body weight, or a clinically significant reduction of 5% in body weight. Obesity is a growing health concern globally. In much of the Western world, strategies for countering the obesity epidemic focus on weight reduction as well as obesity prevention. In the UK, the government has recommended that strategies for the management of obesity should be an integral part of clinical practice. Strategies to control obesity emphasise obesity management and weight reduction. This approach is reliant on the idea that patients may transition from obesity to a more healthy body weight. A target of 5% body weight loss is often recommended for obese subjects who intend to lose weight. However, access to weight management interventions may be limited, and weight management interventions have only small and poorly maintained effects on body weight. In order to understand the frequency with which reductions in body mass index may occur in a large population, this study aimed to estimate the probability of an obese individual attaining normal body weight, or a reduction of 5% in body weight. We use data from electronic primary healthcare records in the UK. The UK Clinical Practice Research Data Link, or CPRD, is an anonymised database of longitudinal patient electronic medical records from general practices. The CPRD is currently the world's largest primary care database. It represents over 7% of the UK population and includes nearly 700 general practices, each contributing research quality data. Participants were classified according to their first recorded BMI, or body mass index value. The groups were normal weight, overweight, obese or simple obesity, severe obesity, morbid obesity, and finally super obesity. A random sample of up to 30,000 participants was selected from each category of BMI and gender, resulting in a total of 314,477 participants. Full CPRD data records were then extracted for the sample. Patients were selected into the study if they were registered in CPRD between the 1st of November 2004 and the 31st of October 2014, were aged 20 years or older, and had 3 or more body mass index records. A minimum of 3 BMI records per patient was required to estimate weight changes, including weight regain following weight loss. 10% of participants who had fewer than 3 BMI values were excluded. There were also 1% of participants with bariatric surgery who were excluded. This left a total of 278,982 participants who were included in the analysis. A longitudinal analysis of BMI records was conducted. The number of BMI records was evaluated for each BMI category. This table shows the initial distribution of the sample by gender and BMI. The mean age was 55 years for men and 49 years for women. The number of BMI records per participant increased with baseline BMI category. We also looked at the number of records showing either an increase, a decrease, no change in BMI category, or weight cycling, both increases and decreases, over 9 years following the first BMI record. The proportion of participants showing no change was greatest among people in the normal weight category and decreased with higher baseline BMI, with the exception of those initially categorised as super obese. Only 14% of men and 15% of women showed decreases in BMI category without increases over the same period. The proportion of participants with records indicating only decreases in BMI increased with baseline BMI category. Weight cycling was observed in over a third of participants and was most common among severely obese and morbidly obese patients. For patients who showed a decrease in BMI category, we evaluated whether subsequent changes represented increases, further decreases, or if no further changes were observed. As you can see from this figure, the majority of patients, 61% of men and 59% of women, whose records showed a decrease in BMI category, then went on to record an increase. The proportion of patients who showed a second decrease in BMI category was highest among patients with morbid and super obesity and was considerably less frequent in lower BMI categories. Data were first analysed in a time-to-event framework to evaluate the proportion of patients from each starting BMI category who attained a normal body weight during the 9 years follow-up. The annual probability of attaining normal weight was then estimated. During the study period, 1,283 men and 2,245 women attained normal weight. The annual probability of achieving a normal body weight was 1 in 210 for men with simple obesity. For women with simple obesity, the annual probability of achieving a normal body weight was 1 in 124. The probability declined with increasing body mass index. In patients with morbid obesity, the annual probability of achieving normal weight was 1 in 1,290 for men. And for women, the annual probability of achieving normal weight was 1 in 677 for those with morbid obesity. In the second analysis, we examined the proportion of patients from each starting BMI category who attained a 5% reduction in body weight during 9 years follow-up. A 5% reduction in body weight was used because this is widely recommended as a target for weight reduction. Annual probabilities of achieving a clinically relevant 5% reduction in body weight were 1 in 12 for men and 1 in 10 for women with simple obesity. Probability increased with increasing BMI category. So for patients with morbid obesity, the annual probability of achieving a 5% reduction in weight was 1 in 8 for men and 1 in 7 for women. The highest annual probability was observed among patients with superobesity. However, among participants who lost 5% of their body weight, 53% at 2 years and 78% at 5 years had BMI records that indicated weight regain to values above the 5% weight loss threshold. We found in our study that the probability of obese patients attaining normal weight was very low. The likelihood of attaining normal weight declined with increasing BMI category, with the lowest probability observed for patients with morbid obesity. The probability of achieving a 5% reduction in body weight was considerably higher, but the majority of these patients went on to regain lost weight. These findings suggest that current obesity treatment frameworks grounded in weight management programs accessed through primary care are not working for the vast majority of obese individuals. The lack of sustained BMI reductions could be driven by both low intervention uptake rates or the lack of effectiveness of these interventions. In a previous study, we reported that weight loss interventions are currently offered only to a minority of patients in primary care. In combination with previous research, this study highlights the current failures in combating existing obesity cases at a population level. It should be stated that it was not possible to evaluate intentionality of weight loss in this study, although we know from previous research that most obese individuals would like to lose weight and a large proportion are actively attempting to do so. We know that monitoring of BMI among obese patients in primary care has been shown to positively predict treatment. Patients in the present study were required to have a minimum of 3 BMI measurements, suggesting an inflated proportion in this sample may have been involved in and interested in weight management interventions. Nevertheless, unintentional weight loss was also included in the study and might result from physical disorders such as cancer or psychological concerns such as bereavement. To conclude, my colleagues and I found that for patients with a BMI of 30 or higher, maintaining weight loss was rare and the probability of achieving normal weight was extremely low. New approaches are urgently required. Obesity treatment programs should prioritise prevention of further weight gain, along with the maintenance of weight loss in those who do achieve it. However, in the absence of effective interventions targeted at the level of the individual, the greatest opportunity for tackling the current obesity epidemic may be found outside of primary care. Wide-reaching public health policies are needed to prevent obesity at the population level. Thank you very much for listening.